As the time is short, we have to hold another meeting. We can only permit 1 or 2 questions from the audience. Rest of the person can ask during the free time.
Madam, because this silver sulfadiazine, the duration of action is small. Can any other antibiotic like betadine can be used, and can daily dressing be sufficient?
Yeah, actually, see, we all do silver sulfadiazine and none of us are doing dressing 3 times a day. But that is the disadvantage of silver sulfadiazine. There is nothing which, that is why these products like Acticoat and all came up, which claim to release the same silver iron over 72 hours. And betadine has been used in some burn centers, but most people have given it up because they have not got good results with betadine. Sucral. Sucral is just a, it's just an emollient and a cover. It doesn't have any antibacterial effect. So you can mix it with some antibiotic and use it.
In electrical burn, how will you calculate the percentage of burn and mix management?
Actually, that is a problem in electrical burns. You have to calculate it by Wallace's rule of 9. But you always have to give much more fluids. The fluids will have to be calculated as 7 ml per kg per body weight. So this is just to offset the deep destruction which has occurred, which is not reflected in your calculation of burns. I think if you saw the morning video where you saw that patient, he just had 2 burns of entry and exit in both the limbs, and how devastating it was. We had to end up at an amputation below the elbow.
And regarding chemical burn?
Chemical burn, don't try and neutralize the burn. Like if you have an acid burn and you don't try and put alkali, because the reaction causes further destruction of the tissue. So the best thing again is just water, wash it off, and then treat as a normal burn.
Last question only.
Madam, how early you would like to give a skin coverage, particularly to the areas where you are moving the areas, like axilla or neck, etc.?
No, actually what happens in all these early burn wound excisions, if the patient is referred to me primarily, then as soon as I can stabilize the patient, say maybe by the 3rd day or the 4th day, we take him or her up for surgery. And then the area we cover depends on the percentage. Say for example, in this boy we covered the neck last, but the neck should be covered earlier because for the anesthetist ease, because if you don't cover the neck early, you're likely to end up have a contracture, and then repeated intubation, so this patient is going to be very difficult. In fact, the patient on whom I showed the pressure dressing needed a fiber optic intubation for release of microstomia.
Role of epidermal growth factor?
Yeah, epidermal growth factors are promoted by many pharmaceutical firms, but there has been there's no case control study on the exact benefit. And they may be only useful in very small ulcers, but when you're dealing with such large burn wounds, you have to give them some cover, either in the form of autograft or cadaveric skin, or then maybe collagen.
Thank you very much, Dr. Malhotra. Now, may I ask the organizing committee to honor Dr. Malhotra with a memento? No?
I would request the chairperson to kindly felicitate Dr. Anjana Malhotra.
Here I would just like to say that Professor Siti Rai Chaudhary happens to be Dr. Anjana Malhotra's teacher. So,
I request now Dr. Kollan Ghosh to please come on stage and felicitate the chairpersons. We have come to the conclusion of the scientific session for today. Members are now requested to stay back for the annual general body meeting in this auditorium. We meet again at BNR Officers Club for the inaugural ceremony to be held at 6 p.m. Thank you.